speakers. Good afternoon, and it's a very interesting and a very important best paper session in memory of our great late friend Ketan Kurjekar. Just before you start, I want to say that Ketan was a wonderful personality, a bubbling, vivacious, and a fantastic surgeon. We all miss him a lot, and this paper session is in honor of his memory. Every year, when we do this from now on, I think it will be in memory of a great personality whom we all miss. So let's start, please.
Good afternoon, everyone. I'll be presenting a study on clinical and radiological outcomes of MIS-TLIF, a study of 345 patients. Over the decades, we have seen lumbar interbody fusion has been used for various lumbar diseases, and of all the prevalent methods, posterior approaches have been preferred. After 1982, after Jorgen Hams has described TLIF, TLIF has been used to achieve adequate decompression and interbody arthrodesis with lesser tissue injury and significant amount of decreased thecal sac retraction. But however, there's concerns about muscle atrophy due to excessive skin incisions and perivertebral tissue damage. With the advent of minimal access techniques, there is preservation of much of these lumbar musculature due to splitting rather than cutting, and decreased intraoperative bleeding due to the tubular system. So the advantages of MIS-TLIF is there is decreased pain immediately after surgery, a faster recovery, a shorter hospital stay, all leading to a faster return to the activity of daily living. Also, there is documented decreased adjacent segment degeneration by preservation of the surrounding structures and the interconnecting tissues. So the aim of our study is to evaluate the clinical and radiological outcomes of the patients who underwent minimal access MIS-TLIF. The study was conducted in Kokilaben Hospital, Mumbai. The duration of study was 2017 to 2020, and it was a retrospective analysis and a 2-year follow-up. Clinical outcomes were measured by VAS scores for back and leg pain and ODI scores. Radiological outcomes were measured by Bridwell grading for fusion under CT. All the patients who underwent MIS-TLIF between Feb 2017 and Feb 2020 were operated by the chief spine consultant of the institute for various spine pathologies have been included in the study. The standard technique is docking of the expandable Thompson tube and the facetectomy of the side chosen, along with the discectomy and interbody cage trials after the thorough preparation of end plates, placement of the cage followed by percutaneous screw insertion under O-arm or C-arm guidance. These are few cases. This is a 43-year-old male sedentary worker, came with lower back pain since 4 years with right radiculopathy, and had a claudicating distance of 100 meters. He underwent a 5S1 MIS-TLIF and showed grade 1 union at 6 months post-operative CT scan. Second, similarly, a 63-year-old coming with a radiculopathy and showing L4-5 instability. He underwent a 4-5 MIS-TLIF and showed grade 1 Bridwell on 6 months follow-up. Case 3, a 63-year-old male coming with 4-5 instability with radiculopathy, 5S1, sorry. This was a sacralized, this was a lumbarized spine. 5S1 MIS-TLIF showing Bridwell grade 1. So coming to our study results, the average age of the patient was 63 years and duration of hospital stay was 4 days. Operative time was 130 minutes mean and blood loss was 120 ml. Return to work was 35 days on an average and fusion time was 6 months. 61% were females and the most common operated level was L4, L5. Coming to the results, VAS score for back pain and leg pain showed significant decrease over 1 to 3, 3 to 6, and 6 months to 1 year follow-up. And ODI scores showed significant decrease or improvement on subsequent follow-up. And modified McNabb showed 93% showing excellent outcomes. Coming to the radiological fusion, 88.5% of the patients showed grade 1 Bridwell and 7.4 grade 2 Bridwell, and 4 were of grade 4. This is the concise results for 345 patients, mean age of 63 years, with 61.7 being female, operated at single institute by a single surgeon, and out of the bed mobilization was done on the same day of the surgery. Coming to the complications of the study, there were 8 dural leaks which were dealt with either sealant or suturing. There was one screw breakage, S1 screw. This patient returned to there was a very early return to the activities of daily living. There were 4 cage backouts where 2 were symptomatic and 2 were asymptomatic. They had backed out into the Cambian's triangle. There was no neurological deficit post-surgery noted, and there were 2 wound gapings which required secondary suturing and antibiotic cover, and they healed. There was no deep-seated infection. Transient neural pain were noticed in 3 cases which settled over 6 weeks, and no conversion into open surgeries from MIS was seen. So discussion, coming to the blood loss, hospital stay and the operative time, our study showed results which were concurrent or along the lines of various studies of high volume, mean blood loss being 120 ml and hospital stay being 4 days, and operative time averaging between 110 to 160 minutes. VAS scores also showed significant improvement along with ODI scores. And fusion rates, these were the significant amount of, there was a significant amount of similarity seen with our study being concurrent with the same lines. To conclude, MIS-TLIF is a safe and effective method for lumbar interbody fusion, showing recurrent replicable results with less perioperative morbidity, less economic and social costs, and early activities of daily living. It has lesser infection rates, lesser blood loss, and equal fusion rates incomparable to open TLIF. Limitations of my study, it was a single center-based study, and this is a short to medium follow-up of 2 years done. Hence, there is a need for longer follow-up. Thank you.